So we do want to welcome everyone. On behalf of the Asthma 411 initiative, we're glad you're able to join us during the lunch hour and take time out of your school day and schedule. I am Courtney Bernard. I'm with the Center for Children's Health at Cook Children's, and we are one of the partners for the Asthma 411 initiative, along with Safer Care Texas and UNT Health Science Center, JPS Health Network and Acclaimed Physician Group, and all of you who are within Tarrant County school districts. And our goal for today's session is to provide timely and relevant continuing education for the school health staff who participate in Asthma 411. So today we'll start off with Leslie Alsop. She's going to give us an overview of Asthma 411 and some brief program updates. And then we'll go to Dr. Phillip Scott and Dr. Christina Robinson, who are going to share the main presentation, and they'll discuss the effects of COVID-19 on our pediatric asthma patients, red flags for patients with asthma, and communication between providers and school nurses. So I'll say one last time before we get started, we do want to make sure everyone had a chance to sign in. So if you have not done so already, in the chat box, there is a link to sign in. If you click on that, it'll open your web browser and you can fill in your name and organization, all of that to let us know you're here. Signing in means that after today's session, you will be emailed a link to the evaluation to hopefully share your feedback. And that is the way you receive your nursing CE if you are looking for that 1 hour credit. So now I'm going to hand it over to Leslie and I will control the slides for you.
Thank you so much, Courtney, and thanks to all of the continuing education team there at Cook Children's. I want to start with a word of recognition and thanks to all the school nurses and the health staff. We know that keeping children and schools and communities safe during the pandemic has been a monumental task and an extraordinary burden for you all. And while you've been meeting that challenge, the everyday needs of health of children at school have not gone away, including asthma. So I know the institutions that are presented and a part of Asthma 411 Consortium want to provide the support and resources for your work on the front line of meeting children's health needs during the school day, and especially for asthma, and improving the health and academic outcomes for children and families that are impacted by asthma. So with that in mind, I'm going to highlight some of the points that we have especially been focusing on, and additionally, give you some ideas of what to look for in the coming year, and hopefully make sure you're informed and also invite your feedback. We know you're the experts on both what the unmet needs are for children during the school day and also the best ways to meet them. So if we can go to that next slide. So looking back at 2020-21, we were largely building the resources and adapting to the needs and challenges of the pandemic. And to start off with, I'll recognize Cook Children's taking their annual Asthma 411 Symposium virtual for the first time in 2020, and we are building on that today, of course. I also want to highlight the Asthma 411 Medical Advisory Council was formed, and I'll be speaking more about that. It continues to be a just critical contribution. We took a number of steps to work and adapt to the COVID-19 pandemic. We worked to replace those nebulizers and the risk that they posed. I want to say a thanks to Cook Children's. They were able to acquire the meter dose inhalers and the light air spacers, which was an enormous challenge during those early days of the pandemic when both were in such short supply. And we also had people pull together from across the consortium to develop those training videos, checklists, and parent education materials. Folks from respiratory therapy at Cook Children's, our medical advisory council, and also the patient safety and health literacy folks at Safer Care Texas and UNT Health Science Center. We started a monthly newsletter Please keep looking for that. It has training tips and opportunities, seasonal information about managing asthma in the Students Corner. We have strengthened the reporting. That really depends on you, but it's so important for the consortium at this point so that we can continue to sustain and improve resources, and it's mandated by the state as well. And then last, working with legislative engagement and some of the state initiatives like the Texas Asthma Controlled Collaboration. So if we can go to the next slide. I want to focus in on the Advisory Council, and a huge thanks to Dr. Haynes. He really stepped forward 4 years ago in 2017 when we first expanded. We recognized that a huge barrier for districts adopting the program was having a consulting position. And by the time he completed his service in that role, Dr. Haynes was the consulting position for 8 school districts. We just can't thank him enough. This summer, he has passed that torch on to Dr. Shelley Sexton with JPS. She is now our Asthma 411 consulting physician and the chair of our Medical Advisory Council. Listed here, we also have the 6 members of the council. They are 6 extraordinary pediatricians who both volunteer their expertise and their time to the efforts of Asthma 411. And I am so grateful to all of them. Dr. Scott and Dr. Robinson are on the call today. Dr. Krahita from Cook Children's Neighborhood Clinics is, he provided a Spanish language asthma education segment for Facebook Live, and that's recorded. We have that available. Dr. Haynes continues to provide consultation on the council, and Dr. Priya Bui is our chair pediatrics at UNTL Science Center. Our next slide, please. I want to thank you all who completed our survey. We do this annually. We distributed this last year to the districts who were able to implement standing delegated orders during the fall semester. 80% of the school nurses and health staff in those districts responded. And there's 4 points that I wanted to provide as a preliminary look on an aggregated basis. First of all, 97% of those who responded indicated they were somewhat or satisfied with the program, which we appreciate and are glad to hear. But there were also 3 important areas where people's comments and feedback focused, and I want to say a word on each of those. First, the role of the MDI light airs and nebulizers. The majority of folks, about 80%, indicated that those were both easy to use and effective. However, an equal proportion said that nebulizers should be available in certain circumstances where a child might have difficulty. I want to let you know that the Medical Advisory Council did review that and responded by making it a part of standing delegation orders to have the nebulizers available as a backup in emergency circumstances. And I want to thank Cook Children's for agreeing to make the supplies for nebulizers available in addition to the MDIs and light air spacers. It really is a barrier of the COVID-19 surge that is still making it an option that doesn't work for all districts. Please look for your district policies for updates in terms of when nebulizers may become available. I also heard loud and clear that those legislative barriers are difficult in terms of getting these written statements from parents that children have a reported history of asthma and permission. And I want to say a word or two about what folks have been doing on our side to try to address these and what we'll be doing going forward. We know it's tough and we are working to try and minimize the impact. I want to thank the Medical Advisory Council. They issued a position statement on this, which they both shared with Texas Pediatric Society and helped to address Texas Pediatric Society concerns about changing the legislation. And we were also able to get a bill introduced by our area representative, which was passed by the House and which would have addressed this barrier. It was also heard in the Senate Public Education Committee, passed unanimously but unfortunately did not pass the full Senate vote. It didn't get heard like a lot of other legislation in the final days of the session. We will keep working on that, and we have put together tools to try and ease the burden of implementing these new requirements and the rules. If you have suggestions, please send them our way. Last but not least, perhaps most importantly, we had a request to strengthen the education and prevention measures. And I'm going to conclude with the next slide, focusing on some of those points to look for next year. So what may be new in 21-22? We are going to work to continue to strengthen and update our online continuing education units and the website. As Courtney has mentioned, this CEU will be available on the website and recorded. We are also going to be updating our fundamental Asthma 411, What You Need to Know website, CEU, and that will be posted. We also are providing a lot of resources on the website, and we want to make sure folks are aware of those and that they are easy to use and to identify. We're going to be updating the website with that in mind. We invite your input. Please let us know if there's ways that we can strengthen that or new resources that will be available. We could see from the survey, that there was not always awareness that we have multiple parent education materials available in 5 different languages. These were requested by our school health administrators. I want to let you know they're on our website, and we will work to make those more easily identifiable so you can use them at the point of care. Those are available in English, Spanish, Arabic, French, and Vietnamese. Those were the 5 languages that were requested. And while Google can help sometimes, everything posted on our website is provided by a certified medical translation service. So all of that information, the frequently asked questions for parents to receive after standing delegation orders have been used, the follow-up education about spacers and the light air, all of those resources are available in all 5 languages. We also are going to be working to pilot an ALA-based comprehensive virtual asthma self-management education, and to develop an asthma-friendly school and SAMPRO challenge. So those 2 programs are going to be led by 2 individuals that I'll introduce quickly. I think they're on the call, though we won't transfer over to them. That's Tracy Chambley and Bobby Brinton. They're 2 advanced practice nurses at Safer Care Texas UNT Health Science Center. Tracy is also a pediatric clinical nurse specialist and a certified asthma educator. So they'll be a great resource for this year. We know that a big barrier to comprehensive asthma self-management education is getting the time to have kiddos be able to, and their parents to participate. We're hoping that by making this available virtually, if you can identify to us who would benefit and who can participate, we can provide that comprehensive asthma self-management education, and we'll pilot that. Please look to your health service administrators for more information. Secondly, we're going to have the Asthma 411 challenge. We know that those basic goals of asthma-friendly schools and now nationally, the School Asthma Management Program, or SAMPRO, really haven't changed very much in 20 years in their fundamentals. They're all a part of Asthma 411. The challenge is, how can we make that happen? And we are hoping that we'll provide a menu to our schools that are participating, that we'll have a group that applies, says they are interested in trying to work on one or more of those program elements, and we can provide some financial resources and technical support. So keep a lookout for that. Last of all, we are going to continue to work on supporting districts and school nurses in meeting the legislative requirements. So last slide. And on that, I just want to end up by saying thank you again to you all. This is my contact information. If you have suggestions on these, please send them our way, my way, Leslie Alsop at UNT Health Science Center, and we will be working to include your input into our program elements as we go forward this year. Thank you all so much.
Thank you, Leslie. We appreciate that. We'll make sure to get your contact information in the chat box. Most people should know how to reach you already, but just in case. We'll now switch over to our main presentation. So we have Dr. Phillip Scott, who is one of the hospitalists here at Cook Children's, and Dr. Christina Robinson, who's the medical director of the Pediatric Mobile Unit with UNT Health Science Center. They're both, as Leslie mentioned, on the Asthma 411 Medical Advisory Committee, and they have both graciously agreed to be here with all of us and share some of their insights, trends that they're seeing related to COVID-19. Excuse me, as well as other topics that might be of interest to you all, especially this year. So I have screen shared, so hopefully you can see that. And I will hand it over to Dr. Scott and Dr. Robinson.
All right, thanks, Courtney. Appreciate it. Thanks, Leslie. Yeah, so I'm Phillip Scott. I'm a pediatric hospitalist at Cook Children's Hospital, and we're going to jump into this presentation, and I agree with Leslie. Thank you so much for what y'all do to take care of kids on the front lines. Y'all are really these kids and their families, and that's incredibly valuable in taking care of their healthcare needs. So thank you for what you do. And I want to kind of send out an appeal before we officially start to say, please, the purpose of this presentation is to talk about these three objectives: COVID-19 pandemic's effect on patients with asthma, identifying red flags, and communication between providers and school nurses. But we're going to try to hit on these topics pretty fast and leave time for questions at the end. So please post questions in the chat box, and that way we can try to address those as we go. But if you have a question, there's probably other people that have a similar question. So please do that. This really is kind of been designed with that in place to be able to utilize that. So please ask questions, post questions. And so as we get started, the first topic we'll talk about is studying the COVID-19 pandemic's effect on pediatric patients with asthma. And if we can go to the next slide. So I am a pediatric hospitalist, and so this is looking at data that we've been collecting at Cook Children's Hospital, and this is you can see on the y-axis over there. This is the number of patients, the number of children that have been admitted for asthma exacerbations at Cook Children's Hospital, and you can see the x-axis is over time. So this is looking at this blue line is 2019, and it's divided up per month, so from January to December, and this is a pretty typical pattern for asthma. You can see there's an obvious dip during the summertime in the number of children that are admitted for asthma. This is typical sort of pattern. In the fall and winter times, we have changing weather, cold weather, viral illnesses that are spreading, so numbers are higher during that time. Summertime, there's a lull in that. And what happened in 2019? Well, COVID-19 is based on the year 2019, because that's when this pandemic started brewing in Asia towards the end of 2019. And so if we can go on to the next slide, please. This orange line is now 2020. And do any of y'all remember what happened in March of 2020? You know probably better than anybody else, because y'all were in schools. My son was he was in kindergarten, right? He went to school, or he came home from school for spring break in March, and he never went back to school, right? I mean, this was major changes occurred around March of 2020. And you can see here, we have just this plummet in asthma admissions during that time. And it's just a very fascinating pattern. It's just really drastic drop in asthma admissions during that time. And I met with our hospitalist group has a monthly meeting that we were at, and I joked with everyone that when we were presenting on our kind of quality improvement projects that we were working on, and they were asking about, okay, how's asthma going? And I joked with them and I said, well, COVID-19 pandemic has cured asthma. Okay, because and everybody laughed because that's they felt that these numbers dropped so low that we really it felt like that there were not many asthma admissions, and people took notice of that. And the person after me at our meeting, she does quality improvement with bronchiolitis, and she made the same comment. COVID-19 pandemic has cured bronchiolitis as well, because bronchiolitis, for those of you that are not familiar with bronchiolitis, it's a lower respiratory infection in infants related to viruses. A number of different viruses can cause bronchiolitis. So we're seeing drastic drops in our admissions for viral infections, and then we saw also a correlation with the drop in our asthma admissions, and that's because viral illnesses are one of the main triggers for asthma exacerbations. So as we did social distancing, as we did masking, we see drop in our viral illnesses, drop in asthma exacerbations accordingly. And if we can do the next slide is 2021. And so we're only partly through 2021 here, but you can see in March 2021, that was when kind of a lot of our social distancing practices kind of stopped and masking kind of tapered off some. And you can see the asthma admission pattern just went right back to the 2019 pattern. And so I think my main takeaway from this data is that just like we expect, kids, as viral infections improve with the social distancing practices, we see a decrease in asthma exacerbations accordingly. And that's just one facet of kind of explaining this data. It's obviously much more complex. There's a lot of complex changes that occurred in March of 2020, but viral illnesses in general improved during that time. At this point, we are seeing some patients that have COVID-19 that get admitted for asthma exacerbations. But I will say that the vast majority of kids that have COVID-19 are not presenting as asthma exacerbations. That's not the typical sort of pattern that we're seeing. It does happen, but it's not the primary thing that we're seeing. And Dr. Robinson, if you can that's from the inpatient side. Dr. Robinson has insight from the primary care physician, pediatrician side. So Dr. Robinson, can you kind of share a little bit about your experience?
Yes, absolutely. Thank you, Dr. Scott. So as Dr. Scott mentioned, I am an outpatient pediatrician, and some of you probably know me from my work with the Pediatric Mobile Clinic. So hello to all my friends out there. So yes, locally here in North Texas, while the emergency rooms and the hospitals had less asthma exacerbation visits, we in primary care world also received less calls and requests for managing acute asthma exacerbations as well. And so I wanted to share a little bit about what was happening in the rest of the country as well at this time. Next slide, please. So the impact of COVID-19 on asthma has been seen throughout our nation. And so emergency room colleagues in the Northeastern United States published on these findings in the article that's cited here on this slide. So when they in their local community had their citywide stay-at-home order, which included school closures, they saw daily asthma ER visits drop to about 5.8 daily averages for the spring, which was about a 76% drop from their normal baseline pre-COVID utilization. And so researchers across the country, including this group, have been looking at it, and those are some of the discussions that Dr. Scott and I were having as well, into the why, right? And so as Dr. Scott was alluding to, there really seem to be three major drivers for this phenomenon. Number one that the researchers kind of picked up on was that there was a lot of hesitance for patients to seek medical care during the early onset of the COVID pandemic. And so a lot of patients were doing everything they could to prevent exacerbations and flare-ups of their chronic diseases. So in our practice, what we saw, we were getting a lot of calls for people to refill their maintenance medications. Patients that sometimes weren't as compliant with taking their maintenance medications were doing so because they wanted to be able to avoid having to go into the ER. Secondly, we felt like that because of that sheltering in place, that social distancing that was happening, patients weren't exposed to the elements, so they weren't being exposed to a lot of the seasonal allergen triggers. And then also they weren't exposed to those respiratory viruses, as Dr. Scott was alluding to. And so those triggers weren't at play either. And then lastly, something that we didn't think about, but just as a natural consequence, because everything shut down, a lot of people were staying in place, there were less industrial and traffic activity. And so we had a decrease in our aero and environmental pollution. And so we know that those are also fairly significant triggers for asthma exacerbations as well. All right, so now I will pass the virtual mic back to Dr. Scott.
All right, can we go to, we have no questions about objective 1. So we'll move on to objective 2. And if y'all, like I said, if y'all have questions, please post them. Yeah, so identifying red flags for patients with asthma. We can go on to the next slide. So this is objective 2. And a lot of this is recap information, right? A lot of y'all know this already. You know, what are the red flags for asthma? You know, the kids will have coughing, they'll have wheezing, they'll have chest tightness, they'll have shortness of breath, and these are all the things that, you know, kids will come to you for, and then you will give them albuterol just like as per y'all's protocols. But I think there's a component to this that's important to look at. That there are red flags both for acute asthma, but then there's also kind of the chronic aspect of this that I want y'all not to miss. And that sometimes the chronic symptoms are the subtleties that can kind of go overlooked, that families begin to overlook because they're just used to it. But and these are not things that you're necessarily going to see as a nurse, but you can talk to families about this, and you can talk to coaches about this. But the kids that are waking up at night, coughing at night, that is a frequent symptom of asthma. And so if you have concerns about a patient and you're talking with the family about you know, how their asthma is going at home, you know, asking about waking up coughing at night, they really should not be waking up coughing at night more than just a couple times a month. If it's more than that, then that's really a red flag that their asthma is not controlled and really need to be on an additional medicine in addition to their albuterol. And the same thing with the other kind of subtlety is cough with exercise or inability to kind of participate in PE or outside during recess. If kids are starting coughing and they're having to limit their activities because of their asthma, this is a big red flag that really we want to try to identify that early and get that information back to the family so that they can get the child to their pediatrician. And so again, there are acute asthma symptoms that we have to be watching out for, and we need to treat accordingly. But also pay attention to the subtle things, as well as, you know, kids that are changing how often they're coming to see you. Sometimes kids will have you know, need an albuterol treatment infrequently, but if you notice that's increase in frequency, that's a red flag to try to communicate to families to get the care that they need. And like Leslie was actually just talking about, is getting people connected with asthma self-management education too. You know, that's a tremendous resource that you could refer them to. So, all right, Dr. Robinson, any additional thoughts that you have, or any comments you want to make on this slide?
Yeah, sure. And so I would want you to return to the asthma action plan, right? So all of our asthmatics should have an asthma action plan, hopefully on file in an ideal world. But even if they don't have one on file, it still gives us a nice gauge of how we should monitor and know when we need to alert others that they are struggling. And so if we have a child that's coming in with those yellow zone symptoms of the cough and the wheeze and the chest tightness and shortness of breath, yes, by all means, we want to treat them. We want to give them rescue albuterol doses, but we want to monitor them to make sure that they're not staying in that yellow zone, that they are able to return back to the green zone where they don't have anything limiting their ability to participate in school or the activities of school. And then if we're seeing red zone signs, that's usually a sign that really we need to get the family involved and we need to get the primary care provider involved as well. So let's go to the next slide, please. So let's say we have a child coming in and you're trying to figure out, is this red zone or is this an emergency? And so those are really key subtle things that also we need to pay attention to. So if the child is not able to complete a sentence with one breath, that's a really bad sign that they are really struggling to breathe. If you're noticing that they have blue fingernails, or if they have been in the red zone, but it's been more than 15 minutes despite having given them the rescue albuterol doses, that means that we are definitely dealing with an emergency situation. And so that's an instance where you do want to go ahead and pause, call 911, notify your principal, of course, and then also notify the parents, the family of that child. So Leslie has done a really great job through Asthma 411 of really giving us some nice framework items. And so I want to remind you of the Asthma 411 standing delegation order algorithm, which really nicely walks through the action steps that we've outlined here today. So the algorithm begins with first looking, does this child have a history of documented asthma? And if they do not have a history of documented asthma, that really is very concerning that they would present with respiratory distress and there's no known asthma. And so then you would want to give the rescue albuterol using the standard delegated orders, but you would also want to notify the family to let them know that this is happening. And you want to complete the notification forms, which is the parent notification form, the primary care provider notification form, and the 24-hour follow-up notice. And you want to have those things ready so that when the family arrives to pick up their child for early dismissal to seek medical care, they can take those documents with them and really convey very clearly to the primary care provider what has happened so that they can, again, provide the adequate care to the child. But in the instance, let's say that the student has a documented history of asthma, then we want to begin evaluating using the additional objective tool of a pulse oximetry. And so we would measure the oxygen saturation. If the oxygen saturation is less than 92%, then we really are in a red zone. And we want to begin giving our rescue albuterol, but we want to begin the process of notifying the family that this child needs to have some same-day medical evaluation, either by their primary care provider or through an urgent care. And you really want to monitor those red zone children very carefully because sometimes they can transition from red zone to that emergent case that we just talked about at the beginning. And in that case, then we need to then notify 911 and escalate the situation. Again, you would want to have those completed notifications form ready and available so that when the family arrives to pick up their child, that they can take that with them so that the right information can be conveyed to the primary care provider or the urgent care provider that will care for that child. If the child has documented asthma, but the oxygen saturation is greater than 92%, then we're likely dealing with a yellow zone exacerbation. And so that's when we would then give the rescue albuterol doses. We would want to monitor, reassess to make sure that they are returning to their green zone and not deteriorating to a red zone. And then we would want to ensure that the completed parent and primary care provider and 24-hour follow-up notice are available to be sent home with the child when they leave school that day. So generally, as the saying goes, it takes a village to raise a child. It really takes a team, a village to control asthma. And so we recognize that you as a school nurse and us as the primary care providers, as the pediatric hospitalists, as the ER providers, we individually alone cannot control a child's asthma. But if we do communicate well, we can do that. And so we also want to add to that team coaches and teachers because they also spend a large amount of time with students. And if they are able to recognize these signs and symptoms as well, they can alert the students and alert yourself that the student is experiencing an exacerbation. And all of the information that can be gleaned from those circumstances surrounding when the child is experiencing exacerbations can then be shared with the family, which can then in turn be shared with the providers that are trying to provide medical care and medical intervention for the child. Secondly, it's also important in the team that we consider the family as well, because in many instances, if the symptoms are not happening at home, the family may not be aware that their child is experiencing these exacerbations. So that is why it's also important to provide those written notices to go home with the family with each instance of the use of the standing delegated rescue albuterol so that they can understand the frequency with which their child is experiencing symptoms. And then that can help you with conveying the urgency of them needing to seek medical care. Okay, no questions? Okay, next slide, please. So if there are no questions about that segment, then we will then transition to our next objective, which is discussing communication about how we can build those bridges between our school nurses and our primary care providers for our students. Next slide, please. So when students require rescue albuterol at school, please complete the parent and the primary care provider and the 24-hour follow-up notice, because those really can be key tools that can be used to convey that information to the families that their student has some exacerbations of their asthma. If they were able to return to class, then that can be sent home with the child. However, if the child needed to have an early dismissal, then that can be handed to the family when they arrive. If students are requiring more than 2 days per month of rescue albuterol, then they are likely experiencing an exacerbation of their asthma. And so those children really need to have the message conveyed to their families that they need to seek medical care to better control their asthma. If a student is in the red zone and is being dismissed early to the family or via EMS, then please ask the family if you can notify the provider on file about their child's asthma status. Especially in those emergency situations, oftentimes parents don't think about notifying their child's provider that something is happening until after the fact. And so it would be very helpful for the primary care provider to know that the patient that they care for has been experiencing a significant severe exacerbation. Next slide, please. So when you are ready to contact a student's provider, please use the completed PCP notice form as a template to communicate with them. So you could fax it to the office. You could call the office and deliver a message for the provider. And I would also say you want to provide that written form to the family as well, so that they have that in hand to provide to whatever provider provides the care to their child when they are seeking care. Now, as we mentioned, ideally, all students with asthma would have an asthma action plan and a medication use form on file. And on both of those forms, there is a PCP designation section where the family would be able to write the contact information, the name, and the office location for their primary care provider for their child. However, we recognize that we don't live in an ideal world, and sometimes that is not the case. And so we have to get a little creative about where we can find that information. We also find that information on sports participation forms, and we find it on food allergy declaration forms. So those would be other places that you could look to find information if you needed to contact the provider for a student. Okay. So I think those were the big points that I wanted to share. We have some references on the next slide, so we can share those. And we want to thank you for your time today, but we really welcome any other questions or comments.
I'll go ahead and stop sharing the screen so we can all see each other here. There we go. And as y'all have questions, feel free to put them in the chat box. I think I'll ask our audience. So anyone, please feel free to unmute or respond in the chat. But I know from our perspective at Cook Children's and the Center for Children's Health, we're really curious to hear from those of you in the schools about what you're seeing in your students with asthma this year. It's been a crazy start to the year. We're hearing a lot from our school partners and across our various programs about some of the challenges everybody's having across the district, but specifically related to asthma, what are you all seeing with your students that you take care of in your offices? And feel free to unmute if you would like to share.
I've never heard nurses be such a silent crowd. Normally y'all are a rowdy crowd.
I remember when we first began discussions and conversations about children returning to the classroom, one of the big concerns that we had was, would a lot of asthmatics end up having exclusion for concerns for COVID when it was actually their asthma? So have we noticed that dilemma this school year?
While folks think on that, I'll note that, is it Cheney? Thank you. Okay, good. Did write in the chat box, she's seeing teachers who, quote, hear wheezing and diagnose. So it sounds like maybe a blessing and a curse that, you know, teachers are on the lookout, helping to monitor the students with asthma, but all of the extra that comes with that, and navigating the communication with the teachers on what that means and how to respond.
And I'll say that's a good point. So one of the first things you learn in medical school about asthma is not all that wheezes is asthma, right? And I'm sure nurses, y'all learn the similar sort of thing. So yeah, I mean, you can have wheezing from viral respiratory infections as well. And sometimes you think you hear wheezing, but you actually are hearing kind of upper airway, kind of nasal congestion. And so it's difficult sometimes to distinguish between the two. And so that's the value that you add as a health provider or health staff in the school, is you can actually listen to their lungs and get a better sense of what's going on. And that's why you're able to kind of be the mediator between what's happening at school and getting that information communicated to primary providers, because sometimes it's hard to know as a primary provider what symptoms are actually being experienced at school, and so you have valuable expertise, and your insight is valuable in communicating to primary providers what's actually going on and how often symptoms are actually happening.
Let's see, Kathleen wrote in the chat that she wanted confirmation that, okay, here we need confirmation here, that we cannot administer albuterol unless the O2 set. Okay, these are, I'm not a nurse, guys, so I don't know.
Yeah, I can read it. Or Dr.
You got
Robinson,
it. Okay, Dr. Scott.
Dr. Robinson, read it, and you can address this question. This is a good question.
Okay, I wanted to confirm we cannot administer albuterol unless O2 saturation is equal to or less than 92%. The orders read to me that they have to meet all criteria in order to give a dose. And so I would say that that is not the case. So we definitely want you to administer rescue albuterol if your student meets the criteria of having respiratory distress or having known asthma with symptoms of an exacerbation, independent of their O2 saturation. Where the O2 saturation comes into play is helping us determine the level of severity of the exacerbation and whether they would need to have immediate medical attention or whether they would be able to return to class. Did any others to chime in there?
Perfect. Yeah, no, I think that's perfect response. Yeah, you don't have to have a saturation. Please, by all means, if they're having an asthma attack and their oxygen level is 93%, they need some albuterol. So give them albuterol. And then next question is from Rhonda Harper. Thank you, Rhonda. The student having an asthma attack and doesn't have the inhaler on file or with her, what is the best thing to do? This is the beauty of the standing delegated order. Okay, this is why we have this, is because basically we have albuterol in schools for kids that don't, they don't have albuterol on file. So if you are concerned that they are having wheezing that suggests that they're having an asthma attack, this is the perfect opportunity to give them albuterol, and that's the whole point of the standing delegated order. And so yes, if you're concerned that they're having an asthma attack, give them albuterol. Children die from asthma because they get too little albuterol too late. And that's the purpose of this, is to get them albuterol as soon as they that they need it. And so treat kids that you're concerned if they're having an asthma attack. Use the albuterol that you have. Next question.
Dr. Scott, I can answer that question. This is Marquita Jones.
Oh, perfect. Yeah.
I wanted to let everyone know that deliveries were made yesterday. I was able to deliver the items asked from the nursing directors or health directors, so Azle, Arlington, Burleson, Crowley, Chapel Hill, Everman, HEB, Fort Worth, and Northwest. So contact your health director to see when they will be arrived to your school. And we did deliver the light air chambers as well.
Perfect, wonderful, thank you. That's awesome. I wanted to tag onto the question for Rhonda. So if you are having a patient that has asthma or is having exacerbations and they don't have an inhaler on file and you're needing to use the standing delegated order albuterol, this is a perfect opportunity to reach out to the PCP and reach out to the family to let them know that this child is having uncontrolled asthma. And that's the beauty of the forms that you have available to you through Asthma 411, to really make very clear communication so that everybody can get on the same page. These are great questions.
I'm want to add just a really quick point as well, and that is just to be sure to be aware of your ISD policy as well. And the Medical Advisory Council wants to do everything that's medically indicated and consistent with that guideline-based care, and make those tools available. But we do need to be aware of your ISD specific policy. And that has become loomed as a bigger issue with the legislative changes that have come into play. So just to point on that, make sure you're aware of your ISD policy. I know that a number of ISDs are working with this in their legal department, and we're working on our side. But it's also a part of the equation. Thank you all so much.
Wonderful. Thank you so much, Leslie, for that reminder. Absolutely. And on the algorithm for the standing delegated orders, you will see a little box that reminds you to make sure that you're compliant with the district regulations and policies as well. So I really found that algorithm was very helpful. And especially in acute situations, it's something that's nice to have a nice visual aid. Do this, do this, do this, so that you don't miss any steps.
We have a new question from Blanca Moreno. We have kids without a PCP and need inhalers. What can we do there? And that's a great question. So asthma is one of the most common, I think it is the most common chronic illness in kids. Chronic illnesses are best managed by a primary care physician. And so those kids need a primary care physician. And so, and there are resources, I believe, Leslie, on the Asthma 411 page that have lists of primary care physicians that you can connect families with. And so I would recommend send that information home with families to establish care with the primary care physician. Sometimes insurance is a problem too. And so those primary care providers may need to have social workers help them get insurance. And I know Dr. Robinson has a social worker actually with her in her bus. That's how in her mobile clinic to connect people with insurance so they can get those things covered. But yeah, get them connected with the primary care physician. Have that information available to families. I believe there are resources on the Asthma 411 website that you can use.
I want to reiterate that. Thank you so much. We have a list of community resources that has our Cook Children's community, a neighborhood clinics, the PMC, the JPS community health centers that are available. If anyone sees another resource that we need to include on that, please let us know. But we are trying to provide that to support your ability to help families get into care. That is the key thing. We know that there's also been a question there about demonstrating the use of inhalers. I don't know if we have time or the supplies right at this moment. I want to let you know that on our Asthma 411 website, we've got CDC videos that will demonstrate that with and without an inhaler. They're only a couple minutes long, so you could even show that to a child if they come into the clinic. And we also have on the website, and it's linked to our quick reference resource guide, a demonstration of how to use the MDI and light air spacer. Again, it's only about 2 minutes long, so you can look at that. If you have any trouble finding it, please send me an email and I'll make sure we get it directly to you. That's critical. Most both parents, adults and children, inhaler technique is a huge concern and challenge. Thanks.
Well, I'll jump in here because we are we're approaching the top of the hour, and I want to respect everyone's time and let us move on to the next thing. But I do definitely want to thank Dr. Scott and Dr. Robinson today, and Leslie for your updates, and for all of you for asking your questions here. If you have other questions that pop up later on or that you didn't have a chance to get in the chat, Please feel free to reach out to one of us and we will work to get your questions answered. You can always go to asthma411.org to contact us, or a few of us will be on the call a couple of minutes after 1, so you can get it in there and we'll get you an answer that way. As a reminder, we want to make sure everyone did have a chance to sign in, so I'll ask Marquita to put the sign in link in the chat box one last time. So if you came on a little later, we use that to capture attendance, and then we also use that information to send you an email with the evaluation. And Jean Hostler is going to send that out tomorrow, so watch your email for that. You must complete the evaluation if you are looking to receive a nursing CE or certificate of attendance that way. Please also remember that today's session is being recorded and we'll have it posted, so we'll keep you notified of when that will be available, and you can share that with your colleagues who weren't able to be here live today, and they can also earn a CE for a short period of time once it's posted. So with that, we thank all of you for being here, and we hope you all have a great day and a great rest of the school. We'll start with a great start to the fall. How about that? We hope you have a great start to the fall. All right, thank you all.